are listening to the Iser Health Podcast with your host, Dr. Josh Gilden.
Disclaimer. The information discussed in this podcast is for educational and informational purposes only. Always consult with a qualified healthcare provider regarding a medical condition or treatment. The views expressed by the guests and hosts are their own and do not necessarily reflect those of any affiliated institutions.
Dr. Mand, the myth, and the legend. Thank you for coming in.
Thank you for having me.
When I think about Iser and what we do here, the first thing I think about is the personalities, right? Like the physicians, the PAs, the staff generally come in, they have a smile on their face, they care for the patient, right? Then you add in talent, right? And like in your particular case, so if you have good front staff, you have a kind clinician who's talented, right? So then you're going to have the optimal care, the one who's the closest to you and cares and is also very knowledgeable, right? So in this particular case, I was thinking that you know that, I know that. We have those conversations. I don't know that everyone knows that, right?
I disagree, yeah.
And part of the issue is just there's always an intermediary to our message, right? Like in order for people to get to us, they do have to cross a couple barriers to get to the back office and actually see a clinician, right? But if you can break down that fourth wall, so to speak, right? If you could have them see you, right? And have them get to know you a little bit and appreciate the personality, the passion, right? Maybe that's kind of the way to get healthcare done in the community, right? So that's kind of the impetus. I'm like, well, how do you do that, right? Because you're treating one patient in front of you, you're treating one patient in front of you. And the common day answer is just you do a podcast, right? Like you get the information out with your voice, so it's authentic. And that's generally, I think that's what created the idea. But, I guess a good question that I have, right, is so when I went to medical school, or even before that, like I have a history in EMS. I was an EMT since 2006. So BLS card since 2006, and it's still current actually, so it's 2025. It's like a point of pride, I guess. But when I went to med school, I knew that I wanted to be in medicine. Did I know exactly what I wanted to do with it? I didn't know exactly what I wanted to do with it. But I felt like there are a lot of different options out there, So I find it interesting when people go into optometry, people go into podiatry, right? Because for me, I didn't have to decide my route immediately, but you kind of just knew out the gate, this is exactly what I want to deal with. And I'm kind of curious, like, how did you come to that decision?
Actually, it's a very, very good question. Now, I'll just kind of give a little backstory about me too, and that kind of leads into why, how I wound up here. So I'm from a family of healthcare. My father was a dentist. My grandfather was a dentist. My great-grandfather was a dentist.
Your father, grandfather, great-grandfather,
yes,
all dentists.
Yes, actually, same practice in Brooklyn up until 2014 when my father retired from private practice and went into more like academic dentistry. Now he's a teaching attending.
But you're saying father, like literally paternal lineage.
Yep.
All the way back.
Jacob Mand, first in the line to be called to be a dentist back in 1909 or something like that.
1909, first dentist.
Yep.
Okay. So you're breaking the lineage.
I broke the lineage. Yep.
Okay, fine. So family of dentists, go on.
So I also my mother worked in healthcare. Works in healthcare currently. She's a clinical lab. Actually now she's manager of the New York Presbyterian Clinical Chemistry Lab. So I've been around healthcare all my life.
So family of healthcare.
Yes. So I kind of always got experience to it, and just generally, I worked even when I was like in high school. I volunteered at the hospital and I enjoyed it. I was I guess the version of a candy striper. They don't really have the candy stripes anymore. But pretty much, you're a volunteer. You helped, move people around, like bringing them from at the time was like, let's say, you need to go to like the X-ray unit. As long as they were not really critical, you would help them with the wheelchair and wheel them down. You also delivered medications to the floor. This is over at North Shore. Actually, at the time it was called North Shore University Hospital.
How'd you get set up with that hospital?
I don't actually fully remember. I remember my mother was asking me when I became a freshman in high school, you had to do a certain amount of community service hours. And I said, well, why don't I do them first at your hospital? She worked at NYU. She said, well, you could, but I lived on Long Island, going into Manhattan, that's going to cost a lot of money, and it's a lot of time, traveling. She said, well, let's see if we can do something local. And I guess she must have made, she at the time was working 30 years. She must have made connections. And she said, well, I think North Shore would be a better place. It's only a 10-minute drive from my house at the time. So my parents were going to have to drop me off and, let's go for an interview. And I got interviewed and, they said, okay, you would be a good candidate for the volunteer program. And I did that for most of my freshman year. I did well over my 40 hours. I did freshman year, sophomore year, junior year, senior year. I did in the beginning, but things just got hectic. Senior year, you're applying to college, and so you just don't have time. So that's kind of where I really got, I guess, into it as an individual, not just from my familial lineage.
What'd you love about it?
So, I mean, one of the things I actually did love at first was the technology. I worked a lot actually in the pharmacy area. So, watching them kind of do some of the mixing the drugs and sort of, all the, different medications was like almost like eye-opening, like, like almost like impressive, like, wow, like look at how many medications there are out there. You think about like your normal CVS, this thing was like 10 times the size. It's almost like, medications for every known condition. It was kind of impressive. Like, wow, we've advanced as, a species to get to the point that, it's not just, a random person mixing up some herbal concoction. It's, you have, hypertension, well, 30 drugs for that. You have infection, 300 drugs for that. You think about like 400 years ago, you had a bacterial infection in your toe. The 25% chance you might lose your leg type of thing. Now here, we're going to give you an IV for one day and take these 10 pills and you'll be fine. Mm-hmm. And so that always was kind of like eye opening to me. And then also, I did a little bit in the ER and just sort of the just excitement, the sort of the, what's a good term for it? Controlled chaos of it was just, interesting and just kind of, just seeing the flow, I guess almost like watching human behavior in that was what kind of really interested me at first. But just also, a lot of times when I went to the inpatient floors, seeing patients, because I used to do both Saturday and Sundays hours, you would see them just improve. And that's, even after a day, someone would come in, in a lot of pain, then even on the next day, you're like, they're doing a lot better. You're delivering their food and you're like, oh, how are you doing, Mrs. Smith? And, feeling a lot better. And like, well, yesterday you were all in pain and that, you were like, dying of pain the first day and now you're not. And that was just, to me, was amazing.
So you did this for a few years.
Yes.
And what was your takeaway?
My takeaway, first of all, was that, it is, extremely almost like a complex system. Almost like it was just eye-opening. And I even felt with my 4 year, takeaway is I still was scratching the surface of it. And it was just also just kind of reinforced that, I enjoyed seeing people improve, helping people in that regard, and just kind of being a positive force in their life. That especially as like a volunteer, like that's one thing. Like I was the one bringing the food or something like that. Like so, to me, I felt good because most people would be happy. Hospital food may not be necessarily the best, but the person who's bringing you your food, especially if you ask for like that extra sandwich, you make them happy. And seeing that on their face, when that smile when you come into the room, that's really definitely kind of got to me.
What would you say you learned about the humanistic element of practicing medicine from those years? Because it sounds like what you're saying is those were essentially formative years where you didn't get paid to do it, right? You had to go on Saturdays, Sundays. Yeah. Those are everyone's favorite days are the weekend days to go to work, right? But you did it for 3+ years and you decided you obviously want to go into medicine. So what was the humanistic element that you kind of took away from your work that kind of carries you through till today? Because I find, because I did EMS, right?
I did actually a little EMS too.
Right. We're getting there. Yeah. We're getting there. The firefighter, it's coming up at a later point. But I found that when I went into people's homes, that it provided me this insight into their lives to take care of them, humanistically different than as an ER doctor or even an acute care doctor. When I see them almost in my house, I got to see them in their house. So I'm just wondering, what was your takeaway that you kind of live with today when you practice medicine from then?
I guess I'm trying to put it a good way. Almost like seeing, kind of understanding and just, the people's reaction. And I think, being able, when you come into a room, kind of reading their reactions to things, that's and that still strikes me today is that I like to read, I get a lot just from reading someone's face. You walk into a room and just seeing just how their face is smiling or whether, they look tense, you can sort of gain a lot of information from that. And, and I find that kind of, almost still follows me today, that I find that, just the facial expression of a person, and that's something I kind of really picked up on when I was a volunteer, really makes a difference. And if you can, and kind of reading the facial expression and adjusting your behavior to that.
Is there a time where you kind of walked into a room thought one way, read a facial expression, and kind of had a turn face with how you were going to approach the patient? Like, is there a specific time you remember?
I mean, yeah. I mean, that happened multiple times. You come in, especially being usually a volunteer, you're usually cheerful. You're not there to ever give bad news, and most of the time, no one's really angry at you. But there was a couple times where I'd come in bringing something, or there's something from the lost and found that they found and bring it up, and I think, okay, I'm going to make this person's day better. And like one time I heard an earful. I complained about the food like this, and I definitely had to kind of take it back, and I tried to sort of first to calm the person down, and then just try to reiterate to them, like, I understand, I'm not your doctor or your nurse. I wish I could help you on this. I can just relay the information. There's one person in particular that I recall that I think they were just listen, anyone in the hospital, it's not your best time. They were not having a good day. And I just happened to be the unlucky person who walked in, and, at the time, I just heard info, and they didn't want to hear. I kept saying I'm just a volunteer. No, I remember the person. No one wants to take responsibility. And he was actually closer to the window, so not near the door. And so, if you're near the door in most hospital rooms, there's two beds, one near the door, one near the window. When you're near the door, you can kind of wave to a nurse and say, "Hey, come with me." I was all the way in the door, and I didn't want to leave this person at all, because I always felt like just saying walking away, I always feel that's disrespectful. Unless I felt really my safety in danger, I would still stay. I say, okay, fine. You sit there, you listen, and I just reiterate, I understand, sir, but I'm a volunteer. I can try to relay your message to nursing. That's the best I can do for you right now. If you want me to do it, and they eventually kind of, like a lot of people, they eventually tired out a little bit. And they kind of say, okay, please tell my nurse. I'm like, okay, well, I'm going to run out to you. I'm sorry you're feeling this way, but I'll grab your nurse right now. And I actually tried to make sure the nurse I can say, listen, this guy's very angry. Please just go there now if you can. I think he's a little calmer, and he'll be more receptive. And
it sounds like the human element that you took away from this time is the importance of a patient advocate. Right, because you couldn't necessarily help the patient at the time. You didn't necessarily have the medical know-how, but in essence, you understood that the patient maybe wasn't in an optimal position to advocate for themselves, being that they're closer to the window, not by the door, and perhaps maybe ignored a little bit more, and kind of almost your duty at that time, because you could be a patient's advocate, to be the interplay between the patient and the nursing staff when they weren't readily available, of course. Which, just personally, I think being a patient's advocate, especially in the ER, right? Like, that's something that I don't take for granted, because in the emergency department, oftentimes people are there without family, right? So if you are not going to advocate on their behalf to consultants, right, admitting physician or specialists that might see them, to really describe the situation, because oftentimes the consultants aren't present, right? So you want to give an accurate description of what's going on. If you kind of sometimes let a consultant dictate the terms when they're not fully aware of exactly the patient's condition, maybe because you haven't portrayed it correctly, that's my responsibility. My responsibility is to make sure that I'm portraying the patient case as precisely as possible and really getting the outcome from a consultant that I'm looking for, right? So I can definitely empathize with, thankfully, more or less on this side of healthcare for now, but I can understand the importance of being a patient's advocate, especially when there isn't one there. Now, so you decided, you had a good experience there, and this is where I'm trying to bridge the gap. I'm going to become a podiatrist. Everyone else is a dentist.
So, okay. So, out of college, at first, I knew I wanted to do healthcare, but I wasn't quite sure. So I took a 1 year leave at the time. And, at that point, that's okay. What do I want to do? I started to actually apply to dental school because, that was just, I guess what you did. But interesting enough, my father wasn't the most gung ho on that. He said, he's like, I don't know if dentistry really is for you. And at the time, he was a little disillusioned with it. He had, he was dropping insurance plans, going, pretty much just doing private pay because of the insurance. So he was like, listen, he's like, insurance is killing dentistry. He was stressed out. He's like, listen, you're working harder for less money, and he's like, you're chasing patients for money. This is a very stressful field. And at the time, I remembered I'd worked for a podiatrist for a little bit in Roslyn when I was in high school. And so I said, okay, what else to do? And I remember, saying, okay, look at podiatry. I had a little experience in that. I also, as a younger individual, I also went to a podiatrist myself. I had difficulty with plantar warts and stuff like that. So I had experienced this even as a patient. And, I just remember, one of the things I do remember best was back in when I was, I think it was like seven or eight, or having a wart removed by a podiatrist. I remember it having no pain. Maybe I had pain at the time, I just don't remember it. But that's one of the things I just remember having no pain, and that kind of stuff. He's like, okay, And the thing is also to the surgical aspect. I knew podiatrists do surgery, and I was always someone who liked to tinker with things. So I was like, surgery. I could see myself doing that, and so I applied. Allopathic medicine didn't really come into my mind. I can't tell you why. I guess really it just.
So you went straight from the teeth to the feet.
Yes, hoof and mouth.
You didn't want to stop.
It's in the center.
Don't pass go. Don't collect $200. You're going straight from the teeth to the feet. Now, regarding the training, what I noticed is something interesting is that some podiatrists, I guess, only do the 1 year of training. But does everyone do I saw that you had the initial year plus the following years. Is that standard or is it?
Yeah, so a good thing. So podiatry training has changed a lot recently. And we're talking about like within the last 15, 20 years. So pretty much now all podiatrists, residents, have to do a residency, and all residencies are 3 years, surgical residencies. And now there's disagreement in the podiatry community whether we should all be doing that, but right now that's the standard, 3 years. So, at least for me, my first year was, very much, similar to an intern year. I did internal medicine, which I won't bore you with all the stories of that. That was a little bit of a nightmare.
Bore me with one of the stories, just one story.
One night when I was on, there was, at Forest Hills Hospital, we were at, pretty much we took call. I was on the medicine team call. And I remember it was busy. I had, I got, constant nurses about adjusting blood pressure medication, which and then I got called in for a code. And I was, I had taken ACLS, but, I had my little quick cheat sheet thing, but I was just like, I'm not the one to be doing this. Where's a second or third year IMED resident? So they're like, all right, I'm like, what do you do? The first thing I just did was just pick up the phone and it was code blue, and luckily another intern was kind of walking around another MD, intern, and he kind of assisted me. So
generally in the hospital,
anxiety producing.
Yeah. Besides for the ER and even the ER, depending on the situation, it's always an anxiety inducing event. Anywhere it happens in the hospital, there's usually the protocols where, unfortunately, the first few seconds are generally by virtue of the condition a little chaotic, but it tends to be that after, the initial person sounds the alarm, since luckily you're in a hospital, you're not too far from a defibrillator, you're not too far from a qualified doctor who can come in and help run the code. And actually what's amazing about it is you have a platoon of nursing staff, and if you're at an academic hospital, sometimes you have a platoon of residents who can come in and help out. So it definitely can be scary though, because you don't want to necessarily see the podiatrist at the code.
Yeah,
it's not exactly the physician you want over there, but if there was a diabetic foot ulcer, I'm sure that would be more of more in your lane for something like that. You kind of mentioned earlier, and I wanted to discuss this a little bit more because you're a firefighter as well, right?
Yes.
And sometimes, people, when you become a doctor, you become a clinician, you become a PA, you kind of leave the volunteer or, the EMS related life behind. But it sounds like you still do that kind of stuff, which I know is not easy given a schedule. So what exactly do you do? How long have you been doing it? And how do you fit it in?
So I've been, generally speaking, I've been a firefighter pretty much this will be my 20th year. But it's the same department, Roslyn Highlands.
This is a volunteer? This is
volunteer,
paid?
Yep. I never went the full EMS track. I did all aspects of firefighting. I drove the truck. I went to buildings both on the truck and engine teams. I did drive the ambulance, for a bit. I stopped because really it took a lot of time. Driving the ambulance always was an hour and a half, 2 hours between when you go to the call and when you go home. So I did that. I was a captain for 2 years. And how I fit it in, pretty much, I'll be honest, I don't fit in that much as more. I've been pretty inactive, very little stuff in the last 2-3 years, mainly just because, life, being a full attending, being on staff and on call at multiple hospitals. I haven't had the full amount of time, though. Now I am starting to get back into it now that I've made my board requirements, which, for a certain amount of cases, so I don't need to be on call as much anymore. Not to kind of, I guess, go on a tangent, but, podiatrists to get essentially board certified in surgery, you need certain amount of surgical cases. And, COVID kind of injured that, and pretty much I had to stick about 7 years worth of cases into 5 years. And so the last 2 or 3 years I've been, every hospital every hospital call I can go on, I was doing that. Anything coming through the ER that was remotely surgical, I would try to be on call for. So I pretty much limited my firefighting to almost a minimum. I went on maybe a dozen trucks over the last 2 years.
What are some of the wildest situations you found yourself in being a firefighter? Because I think inherently speaking, it's one of those jobs like EMS where, scene safety is a big deal, but unfortunately the scene is not safe a lot of the time. So how do you deal with that? What are some situations you found yourself in? What are some tactics that firefighters use to kind of tag each other out of those kind of, tough situations?
So, all right. So now give me a second to kind of think. I almost got to sanitize some of it because I'm not saying that we're super busy. I'm like a city fireman, but there are things that really very traumatic that I have gone through that I don't want to necessarily give the gory details.
You can give us the sanitized.
Okay, so
sanitized version is acceptable.
Yeah, so pretty much
maybe encouraged.
There's been at least my safety in my own life. I almost went into the basement. I go, as I call, choo-choo into the basement. Entering a building. We were making a push. It was all blacked out with smoke, and we didn't realize that it was partially under construction. There was a big hole in the floor, and I started to go into the hole in the floor. The assistant chief at the time grabbed my pack, and another guy grabbed my neck at the time and pretty much threw me back. I didn't realize, it didn't hit at first, but when I got out of the, pretty much the building and we were doing what rehab, everyone drinking, cooling down, it kind of kicked into me that, all right, I was about a quarter second away from probably losing my life.
I noticed that you were the outstanding podiatry resident of the year, second year of residency, if I'm correct. Now,
yes,
I'm sure there's some rotating schedule to it, but how many residents were in your class?
Each year was three. So a total of.
So you had a 33% chance, and one had to get it every year.
Yes.
And second year was your year.
Yes, actually, was there 3 or 4? No, 4 each year.
Do you think you did something specific to earn it that year, though?
Well, that actually, interesting enough, that year was one of my transfer years. So I transferred in from, I was originally partially in Kingsbrook for part of my program. Then, for the 2/3 of it, I wound up in Forest Hills. That was my first year there, even as a second year. What I think actually did it was pretty much, as silly as it sounds, being friendly. I was, I know especially my senior residents, as someone who was always very, I guess, amicable, pretty someone that, pretty much, I never really complained. I would cover for my residents, say, listen, you got a wedding or you have an anniversary you want to go to, I'll take your call. So that, that's what I kind of did. And I was always very, I guess attendings liked generally working with me at that point. There's a couple of attendings that were a little strict and stuff. And I always kind of, they were very, I guess, very, not strict. Yeah, strict would be a good thing. They're very like, you need to do this. And I would always kind of, make sure I was kind of like writing the notes exactly what they wanted. That would kind of make them in a good mood. And therefore they would be in a good mood for the entire day. And, I guess that's kind of what did it. Mm-hmm. I was very surprised about the award either. I didn't think I was going to get it.
Now, fast forward to today, you kind of work in a couple different settings, right? So you work here, obviously. Mm-hmm. You still maintain privileges at hospitals and you do some form of rounding at the facilities?
Yes. So my main one right now is NYU Suffolk, essentially NYU Langone Health Suffolk, which is a new hospital, essentially recently bought by NYU. Mm-hmm. That's my main one. We have inpatient privileges there. Like this week, my practice is on call. So, we have 2 or 3 inpatients. So tomorrow I'm rounding.
What are the kind of cases that you see over there?
So generally speaking, most of it's just diabetic foot ulcers, infections, abscesses, gangrene, things like that. A lot of wound care primarily.
Now, diabetic foot ulcers, I think it's probably a reasonable thing for us to discuss. It's one of those diseases that unfortunately is, I guess, end process, right? Someone has to have gone through a disease for an extended period of time for this to kind of show up, right? It's not that someone got diagnosed with diabetes, their A1C just became high and boom, first day they have an ulcer, right? So it's unfortunately like a insidious process a little bit, right? So by the time they get to you, it's already formed. Now, what have you found? Because I'm sure there's various grades, right? With various treatments, what's your best case scenario if someone like is concerned that they have a diabetic foot ulcer? What should they do immediately? What would your initial treatment plan be? And then also if you can kind of, and I don't want to stack the questions for you, but if you can kind of bring us through the progress as it gets worse and worse, how that kind of changes the treatment plan.
Okay. So, I mean, if anyone's concerned about diabetic foot ulcer, definitely, you see a podiatrist. That's it. I always tell my diabetic patients,
What is a diabetic foot ulcer? Just
a diabetic foot ulcer is, pretty much a foot ulcer that's someone who is diabetic. Now, I tend to actually not like the term diabetic foot ulcer because diabetes itself doesn't cause a foot ulcer. Like, it's what the diabetes does to your system that leads to the ulceration. So like diabetes causes neuropathy where you don't feel. So what that does is that, you can step on like a piece of glass and not feel it. And that piece of glass sits in you for 2 or 3 days, gets infected. All of a sudden, you got a big hole in it because all this bacteria is eating away the skin. Diabetes can also cause problems with the blood flow. Mm-hmm. So it can reduce blood flow to an area, so the skin, becomes much thinner. And then, you get a cut and it just doesn't heal. And, it just gets bigger and bigger and bigger because the skin can't heal it. You're trying to put Band-Aids and stuff on it, but the skin just is too injured. Mm-hmm. So that's kind of like the better. I used to say a diabetic with a foot ulcer, with a neuropathic foot ulcer, diabetic with a
little bit of a change of the jargon.
Yeah, that's kind of my personal thing. I don't think diabetic. That's just a diabetic with a foot ulcer. Okay, I mean,
well, I think it's an appropriate distinction because. Especially the layperson, they hear the terminology and they don't necessarily know what to make of it, right? So what you're trying to do is you're trying to clarify the terminology for the patient, right? Like,
yes.
This is not a diabetic foot ulcer. You have a foot ulcer. This is what a foot ulcer is. It's a consequence of long untreated diabetes, but not directly. It's more indirectly. You can't necessarily feel down there. You could have had an injury that you didn't realize happened, and that kind of progressed over time. So I think it's a reasonable alteration to the jargon. I think that's a good way to actually use it.
It also helps too with how you treat it as well. So because diabetes does play a role in wound healing the hyperglycemia, but because when you have let's say a diabetic arterial foot ulcer, you're going to treat differently than a neuropathic foot ulcer. Mm-hmm. Arterial ulcer, a diabetic ulcer caused by diabetes caused poor blood flow, which led to the ulceration. That needs to be treated by trying to get more blood flow down there. But let's say a diabetic neuropathic ulcer where the diabetes caused neuropathy, which led to an injury, that's treated differently. That's treated with, we need to protect the foot. We need to put it like in a cast or something. Where putting cast on a diabetic arterial ulcer, that could actually worsen it by causing constriction, especially, if the cast tightens up a little bit. So the way you treat it is differently.
So for diabetic foot ulcer or a foot ulcer caused by diabetes, what's the grading system if you just walk us through a general treatment plan for a patient?
So, I mean, there's some technical grading systems. You have the Wagner grading system. You have the University of Texas grading system. I generally don't use a full grading system. I do more kind of I just describe it. I pretty much, my rough grading system is sort of, superficial ulcer, which is just pretty much skin, like a blister or just like a light abrasion. Then you have
So that's like a stage 1?
Yeah, stage 1. Yeah, that would be stage 1. Then your stage 2 is to the subcutaneous, which is like fat. Mm-hmm. It's, sort of if you get a deep cut, usually if you got like a deep cut, like those are the layers that you need to like get sutured up.
Yellowish kind of.
Exactly.
Okay.
Then you have the stage 3, which are usually down to the tendon and muscle, deeper than the fat. And then you have the stage 4, which are down to bone. And usually that is usually the worst because you really can't get deeper than bone.
Bone is bone infection.
Yeah, right. Bone infection. Yeah, and there's different gradings, whether it's infected. So there's some ulcers that it's down to bone, but it's not necessarily infected. It's just maybe a very new ulceration that just probes down there, but there's no sign of infection. The bone's of good quality. There's you take a sample of the bone, it comes back fine, no bacteria. Yeah, but then there's others that are, hey, it's been open for a long time. Bacteria, the bone is, bone's supposed to be very hard, almost like nice hard wood. It essentially starts coming apart like balsa wood.
Right.
Or paper.
What do we do for, let's say someone recognizes it relatively early, stage 1, stage 2, we're just going to use that nomenclature, although I don't know that it's correct.
Yeah, stage
precise,
one,
right.
Stage 1 will be a good thing, a very new
What's your treatment plan? Like how, if I'm the patient, what are we doing for me right now?
So it really depends on, kind of, first of all, your health status, it depends on where it is. First of all, what I do is I do a comprehensive exam, vascular, x-rays, neuro, and where I try to determine, okay, what is this primarily caused by? Is it primarily caused by the neuropathy from the diabetes, or is there a blood flow issue? If I felt, you have a superficial ulcer, but I can't feel your pulses, I'm sending you for vascular testing. And usually at that point, vascular finds some things, revascularizes you. I'm pretty much just telling you, okay, put some bacitracin on it daily, put a little bit of a protective bandage if it's on the bottom of the foot, and 2 or 3 weeks later, a small little dime-sized ulcer turns into a scab and heals up.
So it heals up.
Yeah.
Potentially.
Yeah. Oh yeah. In many cases, as long as the person usually comes in, takes care of it, and gets, their everything else under control, their diabetes, and that things, it heals up. There's a good chance of healing up.
Have you found that working here that there's the opportunity to have that interdisciplinary approach with patients? Like I know from what I do that luckily I get to interact with a lot of different clinicians, yourself included, right? So I get to bridge a bunch of gaps that exist, right? If I see a patient, I'm like, hey, this patient, they haven't gone for blood work in a long period of time. I'm really concerned their cholesterol, their A1C, right? I have a direct line to primary care to plug them back in. And also, if I have a patient that comes in with a foot disease that I'm not necessarily intimately familiar with, right? I also know I have podiatry backup and, beyond the curbside, I can get them fit into a podiatry schedule relatively quickly. But have you found from what you're doing that you're able to kind of also galvanize an interdisciplinary approach?
So I think this facility, the Iser Health Center, definitely has a huge, potential for that. Anytime you have multiple specialties in one building, that really has a great potential for treating diabetic foot ulcers. Because the best wound care centers, they're all multidisciplinary. You have vascular, podiatry, you have plastic surgery, you have endocrinology, you have internal medicine, geriatric medicine. So it's a team approach that really in one building really is an excellent potential right here, especially even in Iser too, because we have definitely excellent people. We have a cardiologist who, cardiology, there is an overlap between vascular surgery and cardiology. We have, great internists, so there's definitely a big potential. When you're in the same building, you can say, okay, listen, your first time you see a patient, sometimes the podiatrist may be the first person to see the patient, even with diabetes. I had a patient once that looked at their medical history, had a little high blood pressure, middle-aged, didn't think much of it. And are you diabetic? No, but had an ulcer the size of a dime on the bottom of their foot, didn't feel anything. Said, okay, this is a little strange. You have no history of any back problems, no history of any alcoholism. All right, let's go, let's send you for some blood work. And I can put them on an antibiotic. It came out A1C of 12.
Wow.
This person was diabetic.
What's normal?
Normal is anything below 6.7.
Yeah.
Well, that's
it's pretty high.
Yeah, it's very high. Yeah, that's dangerous. That person's been diabetic for a while. And it took me a while to get that person to actually see his internist. He kind of lied to me. He said, oh, yeah, I see my primary regularly. I saw him last year. I found out that he hadn't seen him for 4 or 5 years. And it kind of, I really had to push. And, at one point he kind of lied to me and said, oh yeah, I saw them, they're going to, do this. And I said, okay, who do you see? He gave me a name and I called them up and they're like, no, we haven't seen him in 3 years.
So I guess, the thing about the pathology is it's a two-way street, right? Yes, someone can have diabetes, long-standing diabetes, and then develop it. And then you kind of have a pretty clear indication, hey, I think this is diabetic. Diabetically caused foot ulcer, right? But you could also have it the opposite way where you're seeing patients, they have no significant diagnoses, right? Or because they haven't seen a doctor in an extended period of time, or potentially have not had a workup, lab work, right? And you're saying something like, hey, this isn't regular, this is abnormal. You should see your primary doctor. And then when they do that, then you have a new diagnosis that can help kind of, I don't want to say it'll inform you on how you're going to treat both conditions, right? So I think that's pretty powerful and kind of, it does speak to, once again, the interdisciplinary approach, because oftentimes in medicine, we're seeing one angle And if you don't have the ability to communicate with someone else, then you're not really going to be able to address sometimes the root cause of whatever the condition is.
And I want to stress, yeah, absolutely true. When they also think about multidisciplinary, especially in one center, not only for the patient being able to kind of go to different places, but also for the clinicians to talk to each other. Because the truth is, as you probably aware, you're trying to reach out to an outside clinician. It's difficult. Right. A lot of times our schedules don't overlap, or I'll call, let's say, the endocrinologist, but the endocrinologist is with patients, so they're going to call me back, but they get busy and they'll call me back, let's say, at 4:00, but I'm with the patient. So it's that you kind of play tag, and you may not reach the person for a couple of days, where a facility like this, or just any center multidisciplinary facility, you can say, okay, I can go to you and say, listen, hey, I just saw our mutual patient. Did you know they had a foot ulcer on the bottom? Oh no, okay, so what's going on with this patient? And you're saying, listen, I haven't, I was seeing them for, last year they were borderline diabetic, but wasn't quite sure. But I haven't done an A1C in a year with them, so but they may very well be. They're on the borderline. I was a little questioning. They may have gained a little weight, so I'm going to do an A1C next time. But I wouldn't be surprised if they were diabetic now. So that ability to also communicate between clinician to clinician, not just getting the patient to kind of follow through on on actually going to see the doctors and the clinicians.
Now, while we're on the topic of foot pathology, right? Let's do the what, why, and how do you treat it, right? So let's say, for example, plantar fasciitis, right? I think that's probably pretty common.
Plantar fasciitis, okay. So plantar fasciitis is essentially heel pain, also known as the heel spur syndrome, or when you say I have a bad heel spur, that's plantar fasciitis. It's a big ligament called the plantar fasciitis ligament that goes from you can't see my foot, from your heel all the way to your toes. It splits out. And it gives you that pain that you step out of the bed in the morning, it feels like someone jabbed a knife into you. Sometimes it gives you that pain during the end of the day where your heels are just so sore that you need to sit in in a bath of ice. So that's generally what people say. So when people say, I really have a painful heel spur, that's what they're most likely referring to.
So, and I want to clarify, heel spur and plantar fasciitis, they're not exactly the same thing, right?
No, they're not. Well, they're connected, but not exactly the same thing. So heel spur essentially is just a bony prominence in the heel, often caused by a tight plantar fascial ligament. And a tight plantar fascial ligament usually causes plantar fasciitis. So usually a person that's had a plantar fasciitis for a couple months, usually when you take an X-ray, you see heel spur. But heel spurs are generally never the cause of the pain unless they're fractured. Mm-hmm. The thing is that people see this nice sharp thing sticking out of the heel, and that looks sharp. Sharp looks painful. It looks like a knife. Must be my location of pain. It's sharp. But no, it's just the body's, essentially, to not get too technical, but Wolff's Law, the manifestation of Wolff's Law, that bone will grow in the direction of traction forces. So when the ligament is tight and pulling on the bone, the body tries to make the ligament less tight by extending the bone. Okay. So that's kind of what the heel spur is.
So that's what it is. It's basically, it's pulling, bone gets extended out, right? And now, if someone is, first of all, is there a demographic? Is there generally someone who gets plantar fasciitis?
Yes.
Or it doesn't really matter?
So, then let's say I guess the demographic would be sort of a people that are kind of, more sedentary, more overweight. Mm-hmm. People that, definitely either, I find to have had a recent change in weight, not necessarily don't have to go being very fat, but if you're let's say, a change in weight, a good line is 10 pounds. Usually, most of the studies are sort of 10 pounds within a 6-month period. Usually, is a good indication for development of plantar fasciitis.
Now, what are some evidence-based treatments for plantar fasciitis? Because it sounds like it could be finicky. Some people deal with it for an extended period of time.
So pretty much a lot of the evidence is stretching. Stretching is the big thing. Stretching out the heel, stretching out the calf muscle too, because the calf muscle plays a big role in the tightness. So it's doing stretches like that. An anti-inflammatory medication definitely helps for the acute pain. Also wearing more supportive shoe gear, things like that, wearing sneakers, and arch supports, things help as well.
Arches, flat feet, high arches. Mm-hmm. What are they? What's the difference?
So a flat foot, generally speaking, is when you're essentially when you're standing, or when you look at when you're standing, your arch is almost to the ground. Now there's flat foot's kind of a bad term because there's different causes of flat foot. There's primary flat foot where your foot is you put your foot on a table, it's as flat as if you're standing. And there's some people that are called flexible and compensating flat foot where you're sitting in bed, you look at your foot, I've got a decent arch, but when you step down, the arch is gone. So, that's, those, what different types of flat foot are. High arch foot obviously is you look at the arch of your foot and it's peaked. And there's different types too, similar to to flat foot, where that's some are very flexible, where you have a high arch foot, when you're sitting in bed, but when you step down, it flattens right out. Some of them are just so high, very high arched, and you step down, that arch is still very high. Mm-hmm. Usually, though, pain will be at both ends of the spectrum. So plantar fasciitis is interesting in that it can often affects people with very flat feet and can affect people with very high arch feet.
So you got to be somewhere in the middle. Somewhere in the middle.
Usually that's the best. Place. Yeah, but you get a lot of patients that say, well, I don't know how I have plantar fasciitis. I don't have a flat foot. My foot is the opposite. Well, I tell you about that does play a role too. That's the just right. This cough, this porridge is too hot. This porridge is too cold. This is just right.
Now, what's the role of orthotics for these conditions?
So the big role with them, both for flat foot and for high arch. So orthotics, what they do are also known as arches. They provide support to the arch, and how that plays a role is the plantar fascia is one of the major structure of the body that help hold up the arch. So that, if, it's what happens is that if you're, without that support, your body is putting much more weight on that ligament. Now, let's say your ligament's injured from plantar fasciitis and inflamed, you put something in there that kind of helps it up, it reduces the pressure. It's almost like, trying to pull a car, or push a car. You're one person trying to push a big car, you're not going to get anywhere. Then 3 other people come and push with you, all of a sudden, it becomes a lot easier to move that vehicle. You don't have to work as hard, now the car is moving. And that's kind of the way the arches do. They take some of that weight that the ligament was holding, and it starts holding it for you.
Bunions. What are bunions?
So that's an hour-long conversation on itself. No, but
give me the 2-minute version of a bunion and how you treat it.
So bunion pretty much is a big bump coming near the big toe. Often it coincides with your big toe, your big finger pointing towards the other direction, so it looks like it's kind of pushing away from your body. Generally speaking, they're caused by numerous underlying conditions, but a lot of times it's due to dysfunction of the big toe joint. So there's usually something, whether it's arthritis, whether it's, let's say your foot is too flat, that the joint doesn't work right, you start developing because the way you walk pushes the toe towards the outside. So that's kind of how you do it. Now, how you treat them? Well, it depends on really how much how painful it is. I always start with telling patients that the only way to treat a bunion, to get rid of the bunion, is surgery. It's a structural problem. It needs to be fixed surgically. Now, that's not the only way to make it pain-free. So the way to make it pain-free, could be anywhere from just, wide shoes so it doesn't get irritated, orthotics to help kind of prevent that bad motion from occurring around the joint, as well as anti-inflammatory medications, as well as cortisone injections where it becomes really inflamed. Mm-hmm. So that's kind of the key thing is. And my always thought process is unless the bunion's causing pain or there's a risk factor, like if you have neuropathy and like the bunion's causing ulcerations, I tell most patients, let it be. It's not a good idea to do it necessarily for cosmetics because usually you're not happy with the results.
So if it looks funny plus there's pain,
yes,
that's when you want to get checked out.
Yep. Or if it's causing other issues like I'm pain-free, but I can't wear any shoes. I have to wear sandals where it starts to impact your life. So I have to wear sandals in the wintertime, and I've had patients say that, because I don't fit in any shoe, but it doesn't hurt me when I wear the sandals. So I always ask them, is it impacting your life? Yes. Okay. And then we go into the surgical discussion.
What's a Morton's neuroma and why is it called Morton?
That's a good question. I actually do not know why it's called Morton, but what Morton's neuroma is essentially a scarred nerve bundle. So between your toes. So you have nerves that run between your toes that go to the fingers, and
on the bottom of the feet.
On the bottom of the foot, yeah. And just like anything, there's not just over time that nerve can get irritated just from walking, injury, and it gets sort of a scar around it. And that problem is that scar then becomes big enough that it starts rubbing between the toes, almost like like rolling a ball between your fingers. Mm-hmm. And it, can become quite painful at that point. And it's, it can feel like a rock is stuck in your foot. It can feel like, you just, someone's just taking electric, like, almost like electric zapping device, almost like a taser, tasing the area. And that's, kind of what it is. It's a misnomer. Neuroma sounds like a tumor. It's not a tumor. It's a scar. It's not malignant. It's just really a scar, a scarred nerve.
What's the treatment plan for that?
So generally speaking, usually we first start with wider shoes, because usually a tighter shoe because it's between the toes. The toes are not squeezed as much. Usually get relief. We also anti-inflammatory medications if we feel it's very inflamed. Cortisone injections do help. And surgery, as well as orthotics, though orthotics play more role in kind of help preventing it from coming back by allowing the toes to, essentially you could make an orthotic in a way to help the toes spread a little bit more, or the metatarsal bones to be technical, where the toes connect to. You can help it spread a little more and therefore relieve it. But yeah, the end result is, if none of that fails, is surgical excision of the neuroma.
Now, you said you need to widen the toe box, right? So I think that kind of brings us to one of our favorite maladies to treat. It's a podiatrist classic, if you will, ingrown toenails.
Yes.
Some would say bread and butter.
I'd say it's up there in the top, definitely the top 5 conditions I treat. Probably the top 3.
Now, if you, because I've done this, if you look online for like treatment opportunities, possibilities, right, for an ingrown toenail, I've found various different remedies, both commercial and just, do it at home kind of stuff. Anywhere from the cotton wisp to a device that is basically like an anchor on both sides of the nail. And obviously there's the surgical procedure, both a permanent and non-permanent procedure, which you can walk us through. But can you just kind of discuss all of these various treatments, what works, what doesn't work, what's the evidence say, and what do you tend to do for these kind of patients?
Okay. So, I mean, yeah, as you said, there's a whole bunch of different treatments for it. Anywhere from just clipping the corner, to you're putting a wick of little cotton ball so it tries to lift up, all the way to us
So when you say cutting the corners, you mean like a slant back procedure, like cut
like
it
a
all the way
slant back.
down?
Yeah, just
So
curving the piece that's sticking into the corner.
So you basically you follow the nail down, you try and find that piece sticking in the corner. So you're not taking out the whole nail, but you're kind of like
you're just taking like
down.
a clip.
So that's what you meant by that. And when you say the cotton ball, what do you mean by what do you do in the cotton ball scenario?
So this is kind of more of an old school podiatry. What you do is because that thought process is as the nail is growing out, it's getting caught in the corner towards the tip. The idea is that, okay, we need to lift it over the corner. And therefore we put a cotton ball so instead of hitting the pocket in front, it gets lifted and goes over the skin. And that's really more of like an old school thing. I mean, they still talk about it, but at least personally from what I've seen, I don't think it works very well.
Is there any evidence behind that approach? Or
you know what? I've not looked to see if there's any evidence behind it. My guess is that it would be highly variable. I don't think there'd be any good studies because it's patient centric. It's patient centric.
Take care of it.
Yeah.
Right. Okay. What
What
about the clamps or the anchors?
The clamps and the anchors, I have looked at a little bit. There seems to be some evidence.
So, and just for the audience, the clamps and the anchors, it's like literally.
It's like almost like a clamp that's like almost spreads it out.
So you like pulls on both sides of the nail and pulls it up, and
Yep.
and they wear this the whole time, or it's a night. How do you?
So I want to stress that I don't have too much experience. I've never used one before.
Yeah.
I have kind of read some of the research on it. There's different types. Some advertise themselves to be, hey, you just use it for like 2 or 3 weeks, and that's all you need. Others say that you need to use it once a week to keep the nail straight. But the whole idea behind it is it clamps onto the nail and straightens it out. Now, the literature on it, at least from what I've seen, claims to be okay, decent, say it works, but I don't like the studies. There are a lot of like case series, case study where it's like a single or 4 or 5 patients they did it on.
So relatively low level.
Relatively low level.
Right?
Yeah. And at least from my understanding of what causes ingrown toenails, which mostly it's usually the structure of the underlying bone as well as how the person walks, which is not necessarily a decision.
So as far as what causes them, is this because I've been wondering this for a while? Is this theory? Because I've seen patients that come in and I promise they're doing all the things right. They are trying so hard not to have an ingrown again, and they just keep coming back in. So part of me wonders, like, they're listening, they're trying not to let this happen, and it happens. So is there a genetic component to it? And then there are some people that just unfortunately they're not in tune enough to really take care of it enough on their own, and then those people obviously require help. But I've always wondered, like, I think there's some people doing it right, but it doesn't matter. It still comes back.
So this is actually a great topic. That's part of the topic I'd like you to bring up because I want to stress that the majority of ingrown toenails, at least I have seen, are not caused by any action or could be really prevented by any action of the individual. The vast majority of ingrown toenails are genetic, or at least are caused by things that are out of the patient's control. It's not necessarily how you cut the nail, though if you cut the nail incorrectly, you can cut the skin and cause an infection, which can cause a nail to get stuck.
So that would be an error that caused it. That would be something that we actually did, an action that caused an ingrown.
But most of the time, most of it's out of your control. I've always tried to explain to patients, try to show them, and it's hard to show them, to show how deep this is. You know, if the nail is about like 3 to 5 millimeters deep into the, the nail pocket, no amount of wicking is gonna, with a cotton ball is gonna get it. No amount of
can't pull it out.
Yeah, you can't pull it out. You're not gonna be able to cut it out yourself because you have to shove an instrument all the way there. You'll be in so much pain. So much of it is just not anything you can do. It's just, you can try your best valiantly, and it's just due to the structure of your foot, and you don't necessarily have control over that.
So some people, just unfortunate, genetic, whatever it is, they're going to get them. Now, you kind of touched on this. There's another subsect of the population where it's improper nail cutting, right? It's improper shoe size. The toe box actually affects if it's too narrow.
Toe box is the part of the shoe where your toes are, essentially. It's the front of the shoe.
The top of the shoe, instead of it being nice and wide, it's kind of like narrowed up, and the toes, I assume, are hitting each other, and that's kind of interfering with the toenail growth. Now, so those are two causes, but is there anything else that someone could do accidentally that would kind of promote ingrown?
Yes. So, there are injuries in certain sports too. Any sport requires usually a lot of jumping or high impact, or even like
soccer.
Soccer's a good one. Yeah.
I had a bad soccer one a couple of weeks ago.
Yeah. So where you're getting traumatized, and a nail that necessarily wouldn't get stuck in the skin, you hit it on a weird angle, and that skin just impacts into the nail, and the nail gets stuck in there.
So any repetitive kicking motion can kind of set you up for potentially getting an ingrown, right? Okay, so there are some various methods, questionable treatment, questionable efficacy. Someone's coming in, they've got pain in their toe, it's red, it's angry, they're saying what are we doing?
So first of all, I always say, it depends on, if this is the first time. Definitely if it's the first time, you look and say, okay, what, I try to look, first of all, at the nail itself. You look and see, okay, is this what I call a true ingrown, which is it's very deep, and this is just this is getting stuck in this pocket, or if it's something caused by the shoe gear, where I look in the nail and be like, I don't see any spicule, which is a piece that sticks in. I don't think anything's sticking in. I can run my instrument along it comfortably.
So
the border just looks inflamed.
The spicule is, you have the toenail on top, and it goes down the side, and then where the inflamed area is, the idea is that there's probably some nail kind of like sticking underneath there,
sticking
and
like
that's the spicule, like a knife
piece,
causing the
is the part of the nail sticking into the skin. And a lot of times, sometimes you'll look and there's no spicule. What I do is I'll run a flat instrument along the border, and it won't get caught on anything. So if I can go from the front of the nail almost to the back and not get caught and not hurt you,
no ingrown.
There's nothing thrown in. But your border, the side of the skin, is very inflamed, so it feels like an ingrown toenail. At that point,
so that's like a pseudo or a fake ingrown.
Exactly.
Okay, so what do you do with that?
So usually I'll tell them, I'll put a little bastrace, and I'll tell them to soak it in warm water, with Epsom salt to kind of soften it, and to wear a much wider shoe, at least for about a week. Obviously, we give some anti-inflammatories, and if it does look like it's very inflamed, I will put them on antibiotics, because I feel sometimes that maybe there may be a small cut somewhere just from being compressed. In certain cases, if they come back and it's still painful, I will kind of cut the border out, because at that point, it's not necessarily the ingrown, it's just the pressure on the border itself. So it's just, we're relieving the pressure. And I tell them, listen, for now on, just try to avoid the tight shoes. If it's a very, very narrow shoe, just try to avoid that one and get kind of something a little bit more of the round toe box, or just get a bigger size if it's a kid. Sometimes that's a big thing too, is that the kid just outgrows the shoe.
Now, if someone, so it sounds like that's like the conservative surgical remedy. Now, let's say you're looking at the toenail and you're just like, I think I've got to take this portion off. So what is an ingrown toenail removal procedure? What are the options? I know there's permanent, non-permanent. Who's suitable for which option?
So what treatments are? So generally, I say there's 3 ways to surgically, that means to cut out an ingrown toenail. So the first one is called, which we discussed, the slant back. Essentially, what we're doing is just cutting the tip that's bothering you on an angle. We usually, that's very quick. Don't need like any injections. We just kind of maybe freeze your skin a little bit with one of the little cold sprays, and we very quickly go in there with a small instrument, clip. It hurts for 1 second. Usually the person feels a lot of relief. We put a little bacitracin and I tell them, pretty much, put a Band-Aid on. You can do all your normal activity. Just change the Band-Aid twice a day. Put a little Neosporin, Bactroben, Mupirocin, bacitracin on it just for like a couple of days. And, that should be good. Obviously, I tell them this, if it's not feeling any better after like a week, definitely come back. Then the next level would be just, let's say, it's very infected, very inflamed. There's something called a nail avulsion or a straight back. That's where we cut the nail border all the way back to where it grows. That almost always has to be done under like a local anesthetic with an injection, just like you get at a dental office. It requires a little more bandage changes. You're going to be a little more sore afterwards. But you have to change the bandage usually for about a week to 2 weeks. But it's a relatively quick procedure and it works very well usually to relieve the infection and pain. Usually when patients come back in 2 weeks, it's, they're feeling a lot better, they're thankful and they're good. Then the third option is similar to the second option. It's called the permanent ingrown toenail removal or the chemical matrixectomy or, a matrixectomy. That means essentially removal of the nail with removal of the nail unit, meaning the area that grows from the nail matrix. That's where all the nail grows from.
So you're taking out the nail and you're taking out also by the bed of the nail, which is really like the base, which is kind of where the bottom, if you think about that white part at the bottom, that's essentially where it's coming out of more or less.
Yep.
And you're taking the whole thing out and you burn, you cauterize.
Yes,
what do you do
we use a chemical cauterization, essentially an acid, to burn it so that it doesn't grow back. And the goal of that is to pretty much make it so, okay, we take it out and now it won't come back. Now, sometimes they do come back, but it gives you a much better chance of permanently removing it than just cutting it straight all the way back. When you cut it straight all the way back, most of the time, I'd say 8 out of 10 regrow within about 8 months. But the permanent, usually about 9 out of 10 times, doesn't grow back. There's also a variation of that procedure too, called the what they call the cold steel procedure or the surgical excision of the nail unit. It does the same thing where we permanently remove, essentially the ability for that nail to regrow in, but it's done with a scalpel. We cut out almost like a wedge of skin and cut out the unit with a blade and then suture you up. And that's usually something
the most drastic.
Yeah, that's usually after you failed the chemical procedure. We usually do that. So who's qualified to do that? Generally speaking, any podiatrist can do all four of those. Most, ER doctors can do the first three.
I've dabbled.
Yeah. A lot of times I found that a lot of the urgent or even internists or family medicine won't really go more than just either clipping out the corner or, doing a quick nail avulsion. Usually, like you watched me once do it, so you may feel more comfortable. But many times in an ER setting, they're more concerned with getting rid of the infection, getting rid of the pain. Mm-hmm. And that's what the second one, the nail avulsion, the cutting it straight back, that's what does it. And for them, and that's kind of the way you guys say, you said, okay, that resolves the urgent problem. Follow up with a podiatrist and kind of go from there and let the podiatrist kind of handle, if it comes back again.
Yeah, I think from an acute care standpoint, like what I was saying is that so many patients were coming in with, not really paronychia, and just to explain paronychia, it's really like that infection, inflammation, yellow pus that's kind of sometimes at the base of a finger or toe, right? Sometimes that happens when there's long-standing irritation and bacteria build up, and you kind of have to lance that with a needle, sometimes a little bit with a scalpel just to get rid of the infection. So, patients weren't coming in with that. They were coming in just with this real pain induration at the corner of their toe, lateral or medial, outside or inside border. And I felt kind of helpless where they'd come to me and be like, this hurts. And I'd be like, I'm sorry, you're just going to have to follow up with the podiatrist. And I just felt with all the tools that I generally have in a tool bag that I got to be able to figure this out. So I appreciate you actually, you brought me there and I sat there like a medical student again and observed and watched and learned and did some research. So hopefully I think patients I've done quite a few at this point.
Yeah.
I don't know, point of pride, I think, but Dr. Shea said she saw my work. She's another podiatrist at the health center, said it was good work, so I'll take her word for it.
I've seen it too. No
complaints.
I concur with Dr. Shea.
But really what it comes down to is just helping patients off hours to, not everyone can get that 9 to 5 appointment sometimes. And, they're more than happy to get that walk-in kind of ingrown taken care of at 11 o'clock at night. I can't say I would do it, but I know plenty of people have decided to go that route and just being able to provide the opportunity, I think, is what it comes down to. As long as we're doing quality, which, once again, we've had return customers, not in a negative way, not that it's grown back, but, if they have it in another toe or another issue. So definitely somewhat familiar. Now, are there any patient populations, like pros and cons, like who could get the permanent or who can't versus the non-permanent? Is there any patient selection?
There is. Now, most people are eligible for the permanent. Now, the ones that I would say, you definitely don't necessarily want to jump into, or might be a little concerning, or and worse than say maybe contraindicating, meaning that you shouldn't do it, are those usually with vascular problems with blood flow, or patients that are prone to.
And what's the concern there? It won't heal?
Yeah, exactly. Or patients with severe uncontrolled diabetes, even if they have good blood flow, where the big issue is you won't heal because you're burning inside the body. So it's just like, if you lit you lit a match inside your body, that's going to cause damage.
Or creating a wound that won't heal well.
Exactly. Yeah, you're creating a wound, and if you have difficulty healing a wound, you don't want to do that to somebody. Yeah, so that's kind of the thing. So, and I've had a couple of times in my career where I said this person would benefit from it, but they're relatively uncontrolled diabetic. It's not safe, and I'll tell them, listen, get your diabetes under control, get that A1C down to a normal level, and we'll do it then. When it comes to people with bad blood flow, smokers, people that have been smoking for years, sometimes, it's just never safe in that point, unless you're going to quit. Like also smoking is a big one now too. They're finding out.
Risk factor for poor healing.
Yeah, that smoking, those with more than a 10-pack year. There are some studies saying that there's a large complication rates with the permanent procedure. And so at least personally, what I do is I generally avoid doing the permanent on people with a significant pack year current smokers at this point.
Understood. Now, two other pretty significant conditions I think we got to get to, right? So first one's probably the easier one, and the second one is maybe a little bit more interesting for sometimes the patients that we tend to treat, but corns, I would say. So what is a corn? How does one treat a corn?
Okay.
Why is the name corn? Why is it got to be named like food?
So I'll start off. So what is it?
It's similar question to how I asked, why is it Morton, right? Why is it corn?
So to start off, I'm not necessarily sure why it's called corn. That's I'm sure they told me once. It's not one of those things.
The etymology is fascinating to me.
Yeah. Actually, I'm not really looking for it. My only thing is that it's kind of like it's very hard. So it's like a kernel. If you have it like a kernel of corn, that's very hard. It's small. That's where I think that name comes from. But what is it? So pretty much, it's kind of a very hard piece of skin. So a lot of patients call it hard skin, but that's kind of what it is. It's a very, very hard, usually a piece of skin or an area of skin that's very hard, usually overlying like a bone that's very close to the skin. What causes them? Pretty much what it is your body's response to pressure on the skin. So usually on the bottom of the foot, a corn is usually due to either like you have a very unsupportive shoe where you're putting weight on a part of your body that just, there's just not a lot of fat or cushion between the bone and the skin, so the body will build a corn. Or in the cases of a lot of patients, have very tight shoes on the top of the foot where the shoe is constantly rubbing out. So a corn is very much just the body's response.
Whenever there's not enough padding, the body's creating
It's
padding.
trying to create space between the bone. Exactly, padding. Though it's not the softest of padding.
No, it's uncomfortable. But
yeah.
So what do you, when you see a patient come in and the patient's uncomfortable, what do you do for them?
So, the first thing generally, like any podiatrist, is you what's called pare the corn. So that means essentially shave it down.
Why does it have to be another fruit? A fruit and a vegetable?
That's a good question.
Pairing the corn. All right, so what do you do when you pair the corn?
So essentially you cut it with a blade. You cut it down because obviously we want to make the patient comfortable. We want them to leave. We don't want you being in pain. So we cut it down to the safest level we can. We can't always remove it entirely.
So do you have to anesthetize for the procedure, or
most of the time? No, it's pain free because the corn itself, the skin usually has no nerves.
So you just use a scalpel and essentially are able to
shave it little bit by little bit. Sometimes we can kind of circle it a little if it's really small, and we kind of just kind of scoop it out. Most of the time we just kind of shave it like little by little, almost like kind of like shaving a piece of wood. At that point too, what I'll usually try to do is figure out what's causing it. If it's on the top of the foot, almost always it's caused by shoes. I'll look at their shoe and see they're wearing like pattern, and I'll kind of talk to the patient too and say, okay, what kind of shoes do you wear? Because they'll come in with a shoe. I'm like, that looks like that wouldn't cause it. And they'll say, oh no, I have a lot of weddings to go to the last month. I've been always in my nice dress shoes. I said, do they have a pointed tip? And they'll be like, guess. I said, okay, that's probably where it's coming from. Other times too, on the bottom of the foot, what I start to do is a biomechanical exam to see what part of the structure of the foot or how maybe the patient is moving when they stand and why they're putting excess pressure there. And that's one of the key things to understand what a corn or even a callus, which is the same thing, is caused. They're not skin conditions. There are skin symptoms of a condition caused usually by your bones in the structure of your foot. And that's one of the important things because they can't necessarily be treated by creams where like if you have like a skin fungal infection, you put a fungal cream on. It's the skin problem is actually a symptom of a larger problem.
So what you're saying is it's essentially reactionary, right? Like
Yes.
you have a bone problem.
Yep.
And this is your body trying to formulate a solution. Unfortunately, it's not a perfect solution.
Yes.
And that's where you come in to identify the symptom of the reaction to the actual disease that you then have to treat.
Yeah, exactly. Yeah. So both the pairing the symptomatic, treating the symptoms, and then the biomechanics, the evaluating the bones and stuff like that. That's really exactly treating the actual disease to try to prevent it from coming back, or at least reduce the frequency it can come back.
Okay, so pears and corns are now two food items off of most people's list. This one is a tough one. It's pervasive. It comes in two forms, and I just kind of want to go through it a little bit so that we can do the best we can to just really help educate, right? What the problem is, how to identify the problem, how do you treat the problem, right? Let's start with probably the easier of the two. Not that it's easy, but we're talking about foot fungus, right?
Okay. Yeah.
Everyone's favorite topic is foot fungus, right? But it comes in two varieties, two flavors, if you will, if we're talking about the food references. But you have the pure foot, right? And then you have the toenail. And from my understanding, the toenail is way more difficult to treat, but the foot's not easy either. So, first things first, how does one get it? And the corollary of that, how does one prevent themselves from getting it?
So I just also want to start off with that also explaining what actual foot fungus is. So there's a lot of misconception of what it is. So it is an infection. So it's not something you get genetically. It's not something that you get from necessarily eating the wrong food. It is something you catch. Like you can get a viral infection like the flu from catching the flu virus. You can get a bacterial infection from a bacteria infecting you. You can get a fungal infection with a fungal organism. It's not a type of bacteria. It's just its own kind of type of organism. Very similar to like mold and stuff like you may find around your house. So, and it's an organism that is pretty much everywhere. So you can get it usually from exposure. So that's from other people let's say taking a shower in an area where someone has very bad foot fungus. So the mikvah, that's probably a big one here. Because that's almost like
so the mikvah, a ritual bathhouse, right?
Yes.
So there's this is a terrible pun that I apologize for ahead of. There's a lot of foot traffic.
Yes, that's a great.
Right. So because of that, there is just an increased likelihood that if someone had it and they weren't wearing the shoes, that, as you said, it's catchy.
Yes,
someone else
very
can pick it up.
yes. So that's one of the things also to understand too about fungus. It's an organism that resists being killed. It's spore forming usually, so it has these defenses. So a lot of times with like bacteria, you can wash it off. Fungus usually does not get killed by water. Does not get killed by a lot of like low dilute chlorine solutions. So a lot of times mikvahs and pools and those things have some chlorine, which helps reduce bacterial load, but it has a difficult time killing fungus. Alcohol has a difficult time killing fungus. So it's an organism that resists a lot of the normal things we clean with. And that's also kind of the reason why it's difficult to treat. So it can live on the surfaces forever, like even non-skin surfaces. It's hard to kill and it's easy to catch. So, it's kind of, when you start seeing it that way, you see why people can easily, especially in communities like this, can easily get infected with it.
Right. So any communal shower, just any communal bathhouse in general is just at risk.
Yes, absolutely.
So that's how you pick it up. Now, the corollary was, how do you prevent it? So what are ways that someone could potentially avoid picking up an unwanted?
So I guess we'll jump into the prevention. So absolutely. Well, one of the things brought up was wearing some type of shoe, flip flops, the Crocs, water shoes. Definitely, they
not that we support any specific brand.
Yes,
any and all brand of plastic footwear.
Exactly. Exactly. Plastic foot, easy to clean. Those help a lot. They don't prevent it 100% because that organism is also in the water, but it definitely limits that. Also, washing your foot very well. Even just right after with either just regular soap and water. Though for people that are a little more prone or have kind of they're always catching it, I do recommend some type of antimicrobial soap, a chlorhexidine soap, maybe like Hibiclens. Not endorsing necessarily one product, but that type of stuff which you can get over the counter at the pharmacy, and you don't need to go crazy scrubbing it for 5 minutes. Just 30 seconds with a paper towel.
A good wash like that can potentially help.
Yep.
Now, someone gets it. Right? Let's talk about foot fungus, right? Specifically, not on the toe, but on the rest of the foot. What are the ramifications? What are the long-term side effects? Is it a big deal?
So is it a big deal? So I tell patients it's an infection. And obviously, you should try to get rid of infection unless it's not safe for you to do so. So the long-term ramifications of kind of letting it grow, especially on the foot, it can affect the nails, but it can also start weakening the skin. And so your skin peels and it becomes thinner, and that leads you to developing fissures, cuts in the skin, almost like paper cuts on the bottom of the foot, and that can lead to bacterial infections.
So that's an interesting point because it's common in medicine. A lot of the times people say, well, if I don't treat it, what's the worst thing that can happen? And, my perfect example, pediatrics kind of emergency cases, classically a kid comes in with ear pain, right? I find out that they have otitis media, right? An ear infection, inner ear infection. There's pus behind the eardrum. And I'll be asked the question, well, what happens if I don't treat it or if I try an alternative method of treating it? And I say, well, the biggest ramification, assuming this is a bacterial ear infection, otitis media, and the reason why we treat these infections in general is not necessarily usually because of the infection itself. It's usually the sequela or really the subsequent things that can happen from having the infection. So particularly in the case of otitis media, although it's rare, right? A sequela it's right next to the brain. It's right next to the mastoid bone, which is right behind here. And the thing that you fear is if you don't treat it, that it starts making its way inward, right? Meningitis is inflammation around the brain, right? Mastoiditis is inflammation around the mastoid bone that's behind the tympanic membrane. So kind of what you're saying here, and I think this might be true for more things, is sometimes we treat the infection or we recommend to treat the infection, not because, it's not the worst thing to walk around with a little bit of foot fungus, but it is a bad thing to have a sequela of that or a ramification, a subsequent issue where, you have weakening or thinning of the skin at the bottom of your foot.
Absolutely. That's actually a perfect way to put it. Yeah, because for most people, it's not a life-threatening condition itself. I mean, actually, I have once in my life seen a cellulitis, an infection of the leg caused by a fungus, in a non-immuno-weakened individual. It was a very interesting case. But for most people, the fungus itself is not going to usually really hurt you or kill you or put you in a hospital. But absolutely, it will start weakening the skin. It could, especially between the toes, can make a small cut, and then bacteria can get it. And bacteria can cause life-threatening infections through your foot. That's, someone in the hospital, that's kind of what my bread and butter is. But so that's kind of why it's important to kind of treat it.
So we should treat it. Now, what's the regimen? What's the recommended regimen for treating it?
So generally speaking, there's two main ways of treating foot fungus. There's topical medications, and then there's oral medication pills. Usually I start off, if it's just on the skin, mild, you start off with, certain types of cream. I like things like terbinafine cream, Naftin cream. Terbinafine cream is Lamisil cream. It's over the counter. And usually it's about once to twice a day for about 2 to 4 weeks. The newer ones are usually now once a day for 2 weeks. Those are like Naftin. But generally speaking, that's kind of how we like to treat it.
Now, what's interesting about that is I find in medicine, a lot of the treatments that we have for your average condition, they don't go 2 to 4 weeks, right? Like you take these antibiotics 7 days, do 5-day course of this topical, whatever, do 10 days of this. The 2 to 4 weeks I find interesting because I guess it hints to how resistant this fungus is to being destroyed, right? But also from a patient compliance standpoint, like I find that it probably makes it really hard to be compliant with,
absolutely.
Right?
Which is why I tend to like the newer medications, because having someone apply something twice a day for 4 weeks, absolutely right. After a week and a half, usually the compliance rate, especially for children, declines significantly.
I found for myself, every time one of my kids comes down with something, I have to give antibiotics. I've probably forgotten to give it to them by day 3. I mean, it's the human nature component to things.
Exactly. And the difficult thing is, especially with treating like fungal infection of the foot, usually the main reason they came in, which is usually it's itching, especially with the newer medicines, goes away like by the second or third day. So it's hard to, what I try to do, stress to the patient is, or the patient's mother or father, even if the itching stops, use it for the full course. But you'll hear back, oh, you stopped using it after 4 days because he felt fine. And he did, but the problem is the organism isn't fully dead. It's just kind of beaten down a little bit. But you stop applying it, it grows right back out.
So that's I think a phenomenon that happens a lot of the times in medicine, right? You give a treatment plan that's longer than the symptoms, Absolutely. Right? And that's the way to do it, right? I mean, if the treatment plan was shorter than the symptoms, then chances are you're half treating a lot of things out there. So oftentimes we're prescribing treatment plans that outlast the symptoms that required the treatment plan, and then it becomes even harder from a compliance standpoint. It's one thing when you just simply forgot because it was an off day. It's a whole other thing when you kind of look at it and you're like, well, it's more or less good to me. I don't see a reason to keep going here.
So exactly. So that's kind of the big difficulty with regimens. And that's kind of why sometimes things get out of control is that patients will use it for 3 or 4 days, feels great. Okay, a month later it comes back, 3 or 4 days, great. And the longer it stays there, the more difficult it becomes to treat, where at one point it's like, okay, initially 2 weeks with Naftin cream and you'll be fine. You're coming in 2 years later and this thing is just like...
It's breeding some form of resistance, essentially, is what you know.
I don't know if necessarily it's a true resistance, but it's just that it's built up so much that the medication needs to be used for far longer.
Mm-hmm. Now, I guess going to the other side of this equation, we're talking about the foot, and now, we kind of mentioned the toenails, right? What's the treatment plan for people that, start getting these toenails that they seem to crust over, they're getting difficult, brittle, large, unsightly sometimes? They don't appreciate having them. How do they go about resolving that issue?
That's actually, I'm glad you brought that one up. I want to stress first off that toenail fungus is a treatable condition. A lot of times patients come in, not just in AZR, but even in my practice out on Long Island, with the misconception that it's an untreatable condition.
So people see that their toenails changing colors, right? Mm-hmm. It's spreading, and their baseline assumption is this is untreatable.
A lot of times, baseline is it's aging.
Why do you think that is? Oh, because they think it's associated with aging. A
lot of times associated with aging because it tends to be that older people get fungal infections. It's just, a lot of times it's just, mom, maybe dad had it, but when dad had it, dad's, let's say 80 years old, maybe when he started developing it when he was 20 or 30, there wasn't really much out there to treat it. So, people's lives are very busy. It doesn't necessarily hurt them. It's unsightly, but they're so busy and and their mom tells them, oh yeah, I had this for years. There's really nothing you could do about it. And they treat it. My suggestion always is if there's any change to nail, coming. Sometimes it may not be fungal. If it looks questionable, we can take a small sample. It's painless to take, and we send it out to a lab to get it tested. It comes back fungal, we can treat it. If it doesn't come back, it comes back as something else, we can talk about what we can do there. So it's usually a painless procedure, and it comes back, nothing, says, hey, it's just the nail's a little discolored because you had some residual dirt on it. I got to clean a little, but I don't have a fungal infection.
What's the treatment plan?
So the treatment plan, generally speaking, there's 3 ways of treating it. There's either topical medication, those are solutions you put on the nail, oral medication, pills you take by mouth, and laser therapy, which is newer. I always start with pretty much the treatment plan of choice usually I go with is the oral medication, the pill. I find the pill by far, by the evidence and by my personal experience practicing with it, is far more effective because I always stress to patients, the fungus kind of builds a shield up it. I say the fungus infection is not necessarily on the top of the nail, it's underneath the nail. Mm-hmm. So you have this big, thick nail and you're going to get that, solution, you're going to paint it on, it's got to penetrate all that nail to get to the organism. The pill goes through the back door. Goes right into the skin, goes up there. So it's far more effective.
Systemic instead of being topical.
Exactly.
And the topical doesn't penetrate deep enough to really get the job done.
Yep.
Now, when we talk about the pill, this is a medication that someone takes once a day, twice a day, 1 week, 2 months.
So generally speaking, it's a prolonged treatment. So, it's either like 3, 6, even 9 months in certain cases. And the pills can be either 1 to 2 a day or even as little as once a week, depending on what medication you use. I mean, the most common one that is prescribed, at least what I prescribe, as well as I think nationally, is the Lamisil tablet, the terbinafine. That is once a day for 3 months. That is probably the most effective treatment out there for nail fungus. I think most studies show it to be about 80% effective. It's very well tolerated. So it's a very effective medication for nail and even skin fungus. And one of the good things about treating with the pill too is that a lot of people that have this nail fungus also have a skin fungus too. Usually it's the skin fungus that causes the nail fungus first. So it allows you to kill two birds with one stone rather than having them apply two different medications at different times and stuff. You just take the pill in the morning and you can forget about it. It's much easier to remember than putting on a medication twice a day.
So as far as that's the classic approach. That's the allopathic podiatric medicine approach to taking care of feet, right? Now, it's not easy, right?
No.
Because a lot of it takes an extended period of time, requires significant patient compliance.
I want to stress too, it takes even in the medication we take for 3 months, it takes almost a year to fully resolve the issue.
Right. You don't get instant results. Patient has to be super motivated.
Yes.
Now, he's on call. It's important.
Nope. Not important.
Not important. The treatment takes a long time. It's hard to comply with, right? You don't get instant results. It's going to be attractive to look for other ways of treating these conditions. What are other ways, other remedies that people have come in with? And are there any maybe over-the-counter or not commercial remedies, bleach or vinegar, anything that is more natural? Because I think that's an appealing word to a lot of people, but has some evidence and is actually efficacious at the same time.
Absolutely. There are a lot of things out there. I also want to
and let me just phrase that a little bit better. I think that sometimes there's a kernel of truth, and sometimes that kernel of truth turns into a bag of popcorn, right? And it's not necessarily the same kernel of truth anymore. So I just want to know if there are ways for us to advocate for easy, effective remedies that are maybe not so commercialized, but they have some evidence behind them. I don't want to start advocating for a natural approach that really has no efficacy and is not beneficial. So are there any kernels of truth in the herbal remedies?
There are a lot of, to use it for natural remedies that do have some evidence. I just want to stress too, even with any of the natural ones, they almost all take about a year. So anything promising, I tell patients, anything promising next week or 2 weeks, not happening.
So any quick results, snake oil.
Yeah, because it has to, exactly, because it has to do with how long it takes a nail to grow. Just think about how long it takes your nail to grow. That's how long it takes for that infection to go away. But, back to, there are some natural remedies that do have some decent evidence behind it. One of them is tea tree oil. It's essentially a gel that you can put on the nails. It's an oil, and it actually has been shown to have not only softening effects on the nail to make the nail a little more soft or pliable, but actually some antifungal properties. I think it was a couple of in vitro studies, and just from my own professional experience, anecdotal, I have seen patients use it and get results. Usually the nail infection is a little more mild, but it has worked. Another option too is...
So tea tree oil, some evidence, people have had good results. Is there a specific dilution percentage or...
It's just over-the-counter tea tree oil. Yep.
Okay. Safe. It's safe, right?
Generally speaking, yes, but it can cause some skin irritation. Okay. So I always tell patients, be careful about putting it on skin. Another one too, just more of an adjunctive therapy, that means kind of in addition to, is soaks with apple cider vinegar, diluted though. Usually I'd recommend about 4 parts water, 1 part apple cider vinegar, a 20-minute soak daily. Apple cider vinegar.
And this is for a fungal foot.
Yes, fungal foot. And it does have a little bit of evidence for assisting with nail fungus. What it does is essentially, apple cider vinegar has both antifungal and antibacterial properties. Now, you don't want to make it too concentrated because it can actually cause a severe skin reaction. It's just like it's an acid. Vinegar is an acid, so pouring acid on your skin is over daily. Every day is not good, but at low doses, the four parts water, 1 part apple cider vinegar, it can help, though usually it's used in conjunction with some type of true topical antifungal.
So it's not a solo treatment. You can use it in conjunction with the other medication that you're taking. Dilute it appropriately and only use it for the specified period of time if you want to give it a shot, but you don't have to.
Yeah.
Okay.
Another option too, not fully, but kind of, is Vicks Vapor Rub. Interestingly enough.
That's what people smeared on the chest.
Yes, when you have a bad cough.
And you have a cold.
How it works, I can't actually explain it, and not many. Is
there evidence for this, or
there is some? They're not really like a randomized control study, but there are case series studies that have shown, and even
so you put Vicks on the foot,
on the finger,
on the finger,
on the toenail. I don't know
toenail
much of on the skin
for the toenail
for about a year.
Fungal for a year.
Yes. So I mean,
This is low level.
Low evidence. I mean,
Right.
there's
So-
some speculation that has something to do with the menthol in there having some antifungal properties. I have seen a few patients that have succeeded in that.
just solely,
Yeah,
So
I mean-
anecdotally, a couple patients
Anecdotally,
solely.
I mean, one of the recently actually, their patient, diabetic patient, comes in, pretty older gentleman, about 90 years old, comes in a wheelchair. His daughter had been doing it for 2 years. On the big toes, he got around the big toes, and the one of them has actually cleared up, and the other one does look better. I took photos of it on my EMR at one point about a year in, and there was a clinical difference. And she claims that they're not taking anything else,
not doing anything else.
Yeah, I mean, and so whether it's just maybe
Is it possible
happenstance?
for fungal toenails to cure themselves? I mean, do they ever go away on their own? Because I'm just trying to think like my understanding of medicine. I don't understand that mechanism, and I want to be careful because I'm afraid that I'm going to get a bunch of people coming in smelling like Vicks, because they're trying it out. But I just, I'm wondering what the mechanism is there to actually create that, or if it just could resolve on its own.
I mean, it's from what I understand. I'm like you. I don't really ever seen it do that before. I'm sure there's some reports out there that it has happened, but generally speaking, really usually no, because it's especially if it's a very severe infection. If sometimes it's a mild infection, you may get a little resolution on its own. Like it's a streak that's questionably fungal, it may resolve. Usually when you've had it for a couple of years, it doesn't go away on its own.
So tea tree, vinegar diluted appropriately, and perhaps something about Vicks. But is that essentially the gamut of things that you'd even really entertain for people to try?
Absolutely. And I always stress when I try that most of those, really they need to be used with some type of true evidence-based antifungal, whether it's the oral medication, the topical medications, or even the laser, just something else to go with it.
Now, is there ever a time that you see someone using something that you tell them to stop because it's dangerous? Sometimes there's a conception that everything over the counter or everything that says herbal can be safe, but unfortunately it's not always regulated. So there are times where people can come in with something they bought and you kind of look and you say, you really shouldn't be taking that. That could actually be somewhat dangerous for someone in your condition.
So, I mean, I haven't found anything like that with the herbal per se, but I have found over-the-counter stuff. People using like bleach. I've had patients, a few patients, not a lot, thankfully, that would put like bleach towelettes on their toes. And luckily I've caught them usually before. They've been doing it a couple of weeks, and usually they've got a lot of skin irritation. Yeah. Something like that can be very dangerous because bleach, non-dilute bleach, really caustic to the skin. It could really cause bad skin burns. I have seen patients that actually have overused it with tea tree oil. To the point that they've gotten like paronychias, which are inflammation of the skin around the nail, and gotten like an abscess, an infection from because essentially it blistered the nail. Mm-hmm. But it also includes vinegar soaks. I've seen a couple patients that didn't dilute the vinegar enough, and they put their foot into either put like a towel on it with vinegar and caused issues. With the skin.
These alternative methods, probably from an adjunctive standpoint, add very little to the treatment plan. And there's also the possibility that if you're utilizing it inappropriately, incorrectly, certainly from a concentration standpoint, you could be causing some real damage as well.
Absolutely, yeah. Again, that's all thing. Adjunctive, additional therapy. Really, I only see, and the benefit that they have is I believe, very mild, if anything at all. And yeah, sometimes, especially when it comes to liquids, if you don't get that concentration right, you make it too strong, they can cause some, real significant skin issues. Not just something you scratch off, but something requiring medical attention for a prolonged period of time.
You mentioned to me earlier, outside of the room, but you actually have some expertise in diving patients for foot conditions. Mm-hmm. Can you kind of explain what that means? Because I think people are probably thinking of a swimming pool right now. And
yes, so
that's not what we're doing.
No, we're not putting patients in a swimming pool. We're not putting them underwater. What diving means, in a sense of wound care or treating a diabetic foot ulcer, is putting a patient in a hyperbaric chamber. That's a tube that a person goes in where they add extra oxygen to essentially the tube. You've probably seen people have probably seen pictures of it. Essentially, it looks kind of like a tube with a big glass window, and the person's sitting there usually comfortably lying down. And what it does is it increases the oxygen in the person's blood so that more oxygen gets to the wound. And so being that if the wound is having difficulty healing, let's say you have bad blood flow, it's not getting enough oxygen, just like we need to breathe.
What conditions you use to treat with hyperbarics?
So generally speaking, it's limited a lot by insurance company, but I treat pretty much any bone infection, any stage 3 or stage 4 ulceration. That's a very deep wound. As well as certain infections, something called necrotizing fasciitis, so the flesh-eating disease. Those are usually indications that
that's usually a surgical.
Yes, you do that in adjunctive.
It's adjunctive. It's additional.
Yeah, in addition. And I have to stress that too. Hyperbaric oxygen diving a patient is adjunctive. It's not alone a treatment on its own.
Right. So it's just another modality. If someone has a critical, tough to treat condition, that's something you give it a try. What are patients' experiences? I mean, I imagine being in a tube, getting oxygen blown in. I don't know what that feels like, but sometimes claustrophobia and MRIs, is that a factor
Absolutely.
here?
Could definitely play a role, and that's part of the patient selection. I always ask the patient before I suggested, said, do you have an issue with claustrophobia? Have you had an issue where you couldn't complete an MRI because of anxiety or some other thing? But most of the time, most patients who don't have those issues tolerate very well. I've never personally been in it, but the patients that I have, never really had any issues with it. It's very comfortable. A lot of times they're giving like a TV, or sometimes I believe the sound could be pumped in. They can't have their own headphones or anything like that because of the electronics, but a lot of people describe it as relaxing. And the results, at least I have seen, usually when I've used it, I've definitely seen beneficial results where I felt that it made a difference.
Are there evidence-based studies regarding the use of hyperbarics for wound care?
Yes, a lot.
Okay.
Yep. That's why it actually is approved under Medicare and Medicaid and a lot of insurances for certain foot conditions. Not every foot condition, but it is actually approved kind of for the uses I use it for. A bone infection, a deep wound, a very bad infection like the flesh-eating disease, or in a cases where you have what's called critical limb ischemia, where it means essentially that your blood flow is so low to, let's say, the foot, that the foot is at risk of becoming gangrene and dying. So that there's a lot of evidence, which is why they're covered by most insurances. And when you go to wound centers or speak to people who have a lot of experience in wound care, it's one of the treatments that many of us will offer. It's not necessarily like some doctors will recommend it, some doctors don't. They don't believe in it. Most of us who do wound care, I do a significant amount of wound care, do believe in it. The vast majority. It's kind of been sort of an adjunctive standard treatment. It's not necessarily novel, or experimental. A lot of us, we understand the science behind it. We've seen the evidence. We've anecdotally, professionally seen our patients improve with the right indications, and so we believe in it.
So perhaps maybe there's some slight amount of contentiousness, but overwhelmingly a lot of good clinical support.
Yep.
You see a lot of good results in clinical practice.
Yep, when used for the proper indications, yes. It's not a miracle cure, which sometimes some patients do think it is, but
I kind of wish in healthcare we more often than not treated patients as customers or consumers, because I think too often, because sometimes the job is a little bit arduous, a little bit difficult, a little bit long, a little bit tiring. We both worked clinical days, and now we're lights, camera, action, So sometimes when you get tired in healthcare, I think there's an opportunity for you to not identify that what you are trying to do is to, kind of please the customer, so to speak, right? Like you're so sometimes disease focused. Now I'm an osteopathic physician by trade, right? So I'm a DO. So there was always that emphasis of being holistic, having a hands-on approach, which honestly, I think there are plenty of allopathic or osteopathic physicians that see a patient in a holistic fashion. I don't think that's a true branch point in medicine anymore. No. Yeah. But certainly, seeing the patient is more than the sum of their diseases, right? So I find that specifically when a clinician or healthcare gets tired, right? Because we all get tired, it's a tough job. That's when you're most susceptible to maybe treating the patient as a patient instead of a customer or consumer. So in that way, I look at it a little bit differently, where I kind of have to remind myself, like, hey, I'm working at a Costco or a Walgreens or whatever it is. And it's like, you have to have the smile on your face and you have to have that welcoming customer experience, because, healthcare is a two-way street, right? You're on one side of the fence and then you're on the other side of the fence, right? And no matter what the clinician or the healthcare provider went through, I'd hope that by the time they see me in whatever the setting, they can pull it together to be like, hey, Mr. Gilden, how can I help you today? You know, and it's tough and it's not an easy thing to do. But I appreciate what you're saying that while that's true, while what I'm saying, I assume you agree with.
Yeah,
at the same time, consumerization, meaning where the main aim is to please and not necessarily get to the medical underpinnings and how to fix it. That's kind of what's wrong with healthcare, and certainly the future of healthcare. If we try and create, an Amazon healthcare society, and this isn't against Amazon specifically, it's just the idea of having a convenient,
instant
gratification medical service that sometimes you're probably cutting corners, you're probably not getting the comprehensive medical care that you really deserve, which at the end of the day, that's what we're here to do, is to provide the comprehensive medical care.
Absolutely. And I just want to add too, that I feel that, treating a person as a patient, that also treating them with the customer satisfaction, being kind, being, empathetic, coming in with a smile. I think that is the proper way to treat the patient too. So I think, treating a patient is not just, okay, you have this, have a nice day. No, treating a patient is connecting with the patient. That's, to me, that's a big thing too. You're not treating a disease, you're treating a person. That's always kind of the way I've always explained to some of the residents that I taught, that you got to remember that you're treating a person. You're treating a person with this condition. You have to connect with that person. You have to be welcoming, and you have to also change your mood and basing on how they're feeling. If they're feeling anxious, you have to kind of change it and treat them as a person and their behavior as a person, rather than just coming in and saying, "Hi, I'm Dr. Mand. You have this. Okay, turbinafine. We need to put you on terbinafine. All right. Any questions? Have a good day." Rather than saying, "Okay, how are you doing?" Coming in with a smile, and just I always like asking, "How are you doing today?" That's like one of the, I always like coming in usually with an upbeat voice. Even if sometimes I have to take, we've all had busy days. You have to get the door closed, the patient's ready. You take a deep breath, take a sip of water, close your eyes for like 10 seconds, and then go in generally with not always with a smile, because some conditions you don't necessarily want to walk, but always with sort of more upbeat tone. "How are you doing today, Mrs. Smith? Okay, you come, all right, so okay, come following up on this. Okay, you're following up with the toenail fungus. So we're here to discuss, the medication. How are you doing on the medication? Any issues with it?" And always kind of, treating it, kind of not just being like a robot, but definitely having, I guess, more animation in your voice.
Yeah, I guess what you're saying is that because we oftentimes see similar diseases, right? Every patient's different, but sometimes a lot of disease processes are similar, or sometimes the same diagnosis, right? Because you see those frequently, right? And because you essentially, or sometimes at least, you can walk into a room and have a good sense for what the treatment plan is going to be, right? That sometimes you have to stop yourself from falling back on that paternalistic, like, I kind of know what's best for you. I understand that your story is a little bit different, but this is what we're going to do. Almost de facto manner of speaking to someone. You have to give yourself a second and be like, new patient, different experience, unique circumstances. I have to listen to the patient to make sure I'm giving the best treatment plan for this particular patient. Well, that's the correct thing to do. Sometimes you have to stop yourself from falling back on just kind of going into robot mode just when it gets tough,
Yeah, and that definitely happens more towards the end of the day, which is also my feeling. I tell younger residents too. I said, never a bad idea, even if you're running behind, to take a minute or two and just, if you have to cool yourself down. You don't want to. That's one thing too. If you're running behind, you don't want to necessarily rush in. Right, you seem like you're rushing. I always think that's the worst outcomes. You miss things, and the patients can absolutely tell when you're in a rush. Even if you think you're hiding it, they can tell. If you're in a rush, they will tell if you're in a rush.
If you could give yourself one piece of advice when you started this journey, what would that piece of advice be?
That's a good question. So probably, I guess the biggest thing would probably be patience. Because I've always
patient CE or patient TS at the end.
CE.
CE.
And not to take your time. My always thing, I've always naturally been, I like to get things generally done fast. And I get sort of anxious when they take longer than expected. And I guess, when I started this job, would have liked to give yourself patience and just realize in healthcare, things just don't always go according to plan. And don't get anxious over it. And just, and just to realize that, were well trained, and the knowledge will, that you've passed all these points in, you have the knowledge. So just, take a breath, and even if things don't go your way, generally how to fix it. And that's just to kind of calm down, because usually we all had that experience when we're first coming out, and you get a little anxious when something's not going right. So I kind of probably would have tell you gotta calm down as well, and also to understand work-life balance too. Because from the early part of my career, even till now, definitely the work was overtaking the life, and it does start to show. It starts to creep into your professional life as well. Because you may enjoy what you're doing, but which I do, but honestly, you can start to tire of it and get a little disgruntled if you do too much of it.
Burnout.
Yeah, and I kind of had that a little bit earlier in my career when I was working like 6.5 days a week, and I started to dial it back, and I pretty much I start to feel again how I felt in the beginning about the profession, and my life has been far more enjoyable. So I tell definitely young physicians, you gotta that work-life balance is really important, and you don't think about that when you're young.
Yeah, for me, I would say, I think that early on there is a sense of concern for inadequacy, right? I think, especially as an EMT at 16, looking at people that were wiser, older, had more experiences, clinical experience, and seeing where they were at clinically and how adept they were at taking care of patients in specific circumstances, I always felt like, well, that's not me. So it was, you said patience. So it's probably having that patience with yourself as well, as just making sure that, you don't have that level of information. So you just have to let time go by. You have to let the education come to you. You have to work hard. And as you get further in your career and you get more of that clinical acumen, educational experience, bottom line, caring is the one characteristic you can't change, right? If you're someone who cares, it's going to come through, and grab that education, grab that clinical experience, you're going to be great. If you're someone who doesn't care that much and you're in it for the wrong reasons, then you get that education, you get that clinical experience, you're not going to have a refined clinician at the end of the day. So I think I remember being pretty hard on myself for not knowing more than I did, and not realizing that probably more than the knowledge is just simply the caring, which is something at this point in my career, when I'm with medical students, residents, MAs, LPNs, RNs, doesn't really matter. I would say the number one quality I look for in someone who I think there can be a clinical relationship with is their ability to care, how much they care. And honestly, to some extent, it's why I really was happy to have you here for the podcast today, because I do notice when I see you that you care about the patients. You want the best thing for the patient. You strike me as the individual and the clinician where when it doesn't go well, it's keeping you up at night. And also when you're not sure what to do, it's also keeping you up at night because you're trying to figure out a better treatment plan for the patient. And, I wish I could say that's pervasive and everyone felt that way, but medicine's a tough field and not everyone is exactly the same. So I really appreciate you coming in and spending a lot of time with us. I'm excited to continue to work with you, and I'm excited to see, our future collaboration.